Thank you. And I'll apologize in advance. This is my 7th trip to Chile. I continue to understand more and more Spanish, and at some point I'll actually be able to give one of my talks in Spanish. That will be my aspirational goal, but unfortunately not today. So if you have any questions, feel free to interrupt, and I'm happy to clarify. And thanks to Mauricio and Alejandro and all the rest of the team from UDD for all of your generosity and hospitality the last couple of days. I know on behalf of myself and the team from Washington University, we really enjoyed our visit. We're very excited about the partnership that we continue to build. And so what I wanted to talk today about is this idea of what I like to refer to as the learning health record system. And by the end of this talk, you may appreciate a little bit more the satire of having record in parentheses here, and I hope you'll understand where I'm going with this in a few slides. I'll begin, and this is something we do in the United States. Maybe it's not as much of an issue here in Chile, but just a few conflicts and disclosures. I won't read them all. Needless to say, I often say to people, if I give a talk in the United States and I'm in San Francisco or Boston or New York, and I put up this list of companies and other groups that I work with, the response I get is that it? Whereas if I give a talk in other parts of the country, they look at me in a very suspect way. But I will steer clear of these conflicts nonetheless. So I want to begin by laying a little groundwork and talk about this idea of a learning healthcare system. And quite honestly, a lot has been written about this. You can look in the lay literature in the press, magazines, you can look in scientific journals, you can look in government reports, and the really common theme here is this idea that we want to instrument the healthcare environment so that we're producing as much data as we can, and then use that data in order to improve the quality and safety and outcomes of care for individuals and populations. Sounds relatively straightforward, but I think we also know that many of the electronic health records and other systems that we have in place don't always meet our expectations in terms of collecting all of that data in a useful form, and perhaps even more importantly in a form that's computable, so we can do things like deliver decision support or use machine learning to predict outcomes for our patients. And so the dialogue around creating a learning healthcare system has a lot to do with what do we need to change in the healthcare research, education, and delivery environments to achieve this goal? And I want to say at the outset, and I think it's very important to recognize, that the learning healthcare system is not a thing. It's not a technology, it's not a building, it's not a physical object. It's a behavior. A learning healthcare system is a behavior in which we have committed to collecting and using all of this data to support all of the people in the healthcare system, including not just providers, but also patients and their family members. Now, recently there was a really nice publication by Jyoti Pathak and a number of other colleagues in the informatics community that sort of outlined what is truly needed to achieve that behavior that constitutes a learning healthcare system. And the idea here is that we are constantly evaluating what's happening in the environment. That evaluation allows us to adjust our approach to healthcare research and delivery and practice. That in turn generates new data and knowledge that can be used not only locally to design interventions that improve how we deliver care, but also implement them. And that there's a constant sort of push and pull of information and knowledge, both locally and throughout our community of practice. I would say, if nothing else, this slide satisfies the requirement that there is no informatics talk that does not involve at least one diagram with a virtuous cycle that shows that we all have job security because we're never done with any of these tasks. But if you're a bit more tactical and you talk about what we need to achieve this vision of a learning healthcare system, I would argue it's 4 things. What's the first thing? The first thing, as I said, is that we need to instrument the care delivery environment so that every time we interact with a patient, it's an opportunity to learn and improve their care, their family's care, their community's care. And that means we need to think about all of the types of data that inform clinical decision making. Not just what we collect in the EHR, but genomic data, imaging data, environmental data, behavioral data from those patients. All of these data types have a critical impact on both risk of disease and outcomes. And in particular, if we want to promote wellness rather than just take care of people when they're sick. The second thing is that if we do collect all that data, we actually need to make it accessible to all the individuals who need to access it and understand it. It can't be the case that there's just a small number of data scientists or analysts that understand how to get to this data. This needs to be really a democratic asset, right? Something that physicians and researchers and administrators and educators can all get access to and ask and answer critical questions. We also have to leverage technology to close the evidence cycle. So if we find something that's potentially useful, right? Perhaps we build a predictive model that allows us to anticipate outcomes for a patient. We can't just stop with having the predictive model. We need to deliver that information in the right time, place, and format to the people who can act upon it. And I would actually argue that this third bullet is one of the areas where we struggle the most in the informatics community. That we can discover things in the lab, but we don't always translate them into the clinic or into population settings. And then importantly, we have to continuously measure, find out if these interventions are working, and then improve them. And this is another factor that I think is very important. The deployment of technology into the clinical environment can't be a unidirectional process, right? We have a new technology, we install it, and we give it to our care providers, or to our patients, or to other key decision makers. We need to put that technology into the real world, evaluate it, learn what works and what doesn't, and then cycle back and optimize the technology. And it's a continuous process. I often say to people, if you believe that installing an electronic health record or some other healthcare information technology is a project that has an actual endpoint, you are mistaken. There's no endpoint to these projects, because installing the software and making it available to your end users is step number one, right? In a almost infinite process of continuously evaluating and optimizing. Now, the way I describe that, you'd say, well, that doesn't seem that hard, right? We're going to collect all the data, we're going to make it available to people, we're going to design interventions based on that data, and then we're going to continuously evaluate and find out if they work. And individually, none of those things sound particularly challenging, but I think we could all agree that we're not doing particularly well at realizing that promise of a learning healthcare system right now. Why is that? Well, a few factors that make it a bit complicated. One, and there's been some interesting reports recently on this topic, is the usability of these tools, right? So many of our clinician colleagues describe sort of the use of modern electronic health records as sort of a function of dying a death by 1,000 clicks, right? That they're so difficult to use, that they're so complex that it makes it almost impossible for them to interact with their patients, let alone document the data and information that we're asking them for. And unfortunately, this is a pretty real phenomenon, right? If we design technologies just around what data we want to collect, without understanding the real-world workflow, the human factors, we often fall short of the type of usability that our clinician colleagues really need. We also know that the ability to move data from one place to another is very challenging. And it's not just technically challenging, it's also challenging from a policy and cultural and business standpoint. In the US, we talk a lot about a behavior that we call information blocking, wherein even if the technology allows for data to move from one provider to another, the providers won't allow that data to move. So why is that? Because it's really in the best interest of the healthcare providers to keep the patients in their system. There's not a business incentive for them to allow people to take that data and their care and go elsewhere. And we need to overcome that. We also have the issue of AI in healthcare, right? And it's certainly a topic of great discussion. And I think part of that discussion is, where does AI work and where does it not? A concrete example that's gotten a lot of coverage in the lay press in particular is that of IBM Watson, right? What's the fundamental problem that Watson has encountered? Well, early on, they trained a series of decision support systems to help predict outcomes for cancer patients. And they did it at one of the best cancer centers in the United States, Memorial Sloan Kettering. And they got good results there. And then they took that system and they sold it to other healthcare systems. And guess what happened? The patients in a community hospital in Florida didn't look like the patients at a major cancer center in New York City. And so the recommendations no longer worked. Because the approach to deploying Watson in the healthcare environment was treated as an engineering problem, as opposed to a clinical problem where we needed to look at reproducibility and sort of efficacy and safety of these recommendations. And you're going to hear me say this more than once in this talk. I believe that AI is one of the most powerful tools that we have to change healthcare. But we have to study it just as rigorously as we study a new diagnostic test, a new medication, or a new procedure. And we're not doing that yet. However, it's not all gloom when it comes to AI, because we're also seeing glimpses of what it can do. For example, work done by a number of companies, including Google, that showed that artificial intelligence agents could interpret chest x-rays and other forms of imaging better than human radiologists. And that this allowed for greater throughput, faster decision making. So this is the other end of the spectrum. But this is not easy either, because if we were to put this into the real world, we'd actually be taking business away from the radiologists who actually read those images today. So how do we address that? That's not a technical problem, that's a cultural problem. And then lastly, what happens beyond the clinic and the hospital, right? We have people walking around, and I'm sure if I ask the question, everyone in this room has a smartphone in their pocket, right? That smartphone can produce more data about your health and wellness than anything we know about you in the electronic health record. And that space, the apps that we can use to monitor health and behavior, is exploding. We have no idea how to connect that data with the data that we have in the electronic health record or these other traditional sources. And in fact, right now, it's quite embarrassing. We have patients showing up in the emergency room in my institution who have had cardiovascular events. They're wearing a smartwatch, and their doctor says to them, do you know what your pulse rate was when you were feeling those symptoms? And the best they can do is pull out their phone and page through it and find the recording on their own personal device and show it to the physician. There's no technical reason why that should be the case. If you're a patient in that healthcare delivery system and you're wearing that smartwatch, why is that data not flowing to the electronic health record so that physician in the emergency room or otherwise can use it for decision making? So my point is, this is a complex environment with many complex technical, cultural, and policy challenges. So I always tell people in my institute that I like to have no comments made that are what I like to refer to as the cheap seats. And the cheap seats are identifying a problem without identifying a solution. So my team knows, don't come to the table and tell me about a problem unless you actually have an idea on how we're going to fix it. So I'm going to give you my idea about how do we fix some of these fundamental challenges that I've just laid out for you. So I'm just curious before I start talking about this, has anyone in this room ever read this book, Pasteur's Quadrant? Anyone other than me? Okay, I'm giving you all homework. Everybody working in engineering, the health and life sciences, everyone should read this book. Because what this book does is talk about how we arrived at the way in which we think about science today. And the way we generally think about science today as this is as a dichotomous enterprise between basic and applied research, right? We have basic research where we come up with new theories and methods, and then we have applied research where we evaluate those theories and methods in the real world and see if they have any efficacy. But we also, in this sort of dichotomous world, think of basic and applied research as completely different, right? The basic scientists don't engage in applied research, and the applied scientists don't engage in basic research. And actually, in the US, this is enshrined into how we build our universities, how we recruit and incentivize faculty, how companies approach research, how we fund it. This is sort of continuous. But in this book, which talks about the origins of sort of this dichotomy, the author actually proposes a third pathway. And I want to talk more about that third pathway, right? As I said, this sort of dichotomous world is enshrined in science, and actually Vannevar Bush wrote a report that basically defined the modern research enterprise in the US called Science, the Endless Frontier, that basically made this a matter of policy in our country. And in contrast, the idea is that perhaps we need a third pathway, use-inspired research, where basically we're developing new basic science theories and methods and applying them at the same time. And this is different than translation. You hear people talk about translational science, and the idea is that you have people that are experts in getting knowledge from the basic scientists and making it useful for the applied scientists. That's not what we're talking about when we talk about use-inspired research. What we're talking about is conducting basic and applied science at the same time with rapid cycles of innovation in both areas. And I think in the healthcare community, as we think about building learning healthcare systems, this type of use-inspired research is absolutely essential. But it's very hard, right? Because if we're going to do rapid translation, as I'm describing, we're going to do that in the clinic and in the hospital and in people's homes, not in labs. And that's a much harder place to do the work. Now, in many ways, I think from my time here in Chile, you're in a much better position to do that because of the interesting relationships that you've been able to build between your healthcare delivery systems and your researchers. And perhaps you will excel in delivering upon this promise of use-inspired research more quickly than we will in the US because of the way we built our system. So, if we decide that we're going to focus on use-inspired research in order to overcome these challenges intrinsic to building a learning healthcare system, we need a laboratory. I just said that this is a hard thing to do because it's not a basic science laboratory, it's not sort of a traditional clinical trial, it's something in between. So what is that living laboratory for creating a learning healthcare system? Well, spoiler alert, it's the electronic health record. Despite the challenges of using the electronic health record, the EHR is the perfect living laboratory to engage in use-inspired research that will deliver on the promise of a learning healthcare system. Why is that? Because they have real-time data or near real-time data about all of our patients, right? Not a week old or a month old. We can actually intervene and measure outcomes in a matter of minutes, not hours, not weeks, not months. It's also important because EHRs are starting to evolve to go beyond just the traditional view of what happens in an exam room or in a hospital room, but also to include things like patient-generated data, if patients report symptoms, or data collected through patient portals and the like. And so when you put those two things together, along with the ability, if we get past information blocking, as I mentioned earlier, to allow us to share data between EHRs, which is not particularly hard from a technical standpoint, we start to create a longitudinal view of what's happening in patients and populations. So I'm going to argue that the real-time nature of the EHR, which is constantly expanding to include more and more data types, and the technical ability to connect multiple EHRs together across the continuum of care for patients and populations, is the very reason why the EHR is the living laboratory for building a learning healthcare system. And EHRs have these critical building blocks or features that make it possible for us to do the work I'm proposing. They are in close proximity to all the people we need to interact with, right? Providers, patients, community members. They can collect lots of different kinds of data. We can customize them. If we want to make a change today or tomorrow or next week, we can change them to meet these types of needs. They can scale, right? They are built to be used, not just in a lab or in a small study, but they're built to be used for large volumes of patients. And I would argue that this type of research requires us to look at large volumes of patients and this potential for interoperability and data sharing. But when I say that, and especially when I give this talk in the US, I get a lot of people in the room that look at me like I'm crazy. And they say, wait a minute, the EHR is way too hard to use for this type of research. You're never going to be able to pull this off. There's all sorts of problems. You're being a bit naive, right? And usually they cite four things when they sort of get concerned about this idea. First, they'll say the way in which the EHR fits into sort of the real-world workflow of our clinicians and patients and other key individuals, it just doesn't work well, and they're difficult to use. So the data can't be trusted because people don't know how to interact with it well. Or they'll say, you know, there's a lot of regulatory frameworks around data confidentiality and privacy that make it very hard to share data for this type of research. You're never going to be able to get past that. Or they'll say, if you're working with a vendor for your EHR, the vendor is going to make it too hard. They don't want you to do this, so they're going to throw up all sorts of roadblocks to customizing the EHR. Or, and I'm sorry, Alejandro, and for others in the room, the IT organization is just too hard to work with. There's no way we're going to be able to pull this off because they're just difficult and obstructionist. Okay? And the question is, are these facts? Are these real problems? Or are they myths? And I'm going to now sort of go stepwise through these, and I want to talk a little bit more about each one of these concerns. As you can tell, I don't believe any of these to be true because I'm labeling them as myths. So myth number one, workflow and human factors are so problematic around the EHR, there's no way we can use the EHR as a vehicle for this type of innovation, right? That's a common complaint that we might hear. We have a ton of tools to make sure that the electronic health record works for our providers, for our patients, and for our researchers. We do not have a deficit of tools and methods to be able to study and make adjustments in the way in which we use the EHR to make sure that it is accessible, that it's usable, and that it's efficient at the point of care and beyond. And you see here a number of different tools that are well understood across the spectrum from sort of purely qualitative research to empiric usability studies to cognitive psychology and lots of stops in between. And these have literally been studied for decades. We know how to do these things. We know how to measure these phenomena, and we know how to feed that information back. I'm not saying that we always do that, but we certainly have the tools to do so. So I want to highlight one of those areas, which is time and motion studies. It's a topic very near and dear to my heart because I've done a lot of research on this, actually with a colleague here in Chile, Marcelo Lopetegui. And these are tools and processes that allow us to go into the real world and see how are people using technology, what are the barriers to effective use, are there opportunities to overcome those barriers, and can we measure them? How frequently do they occur? What is their real impact? Are they a perceived barrier or an actual barrier? And there's a broad variety of tools and methods for doing these types of workflow studies. One of them that's quite powerful is called a continuous observation time and motion study. We actually put people into the clinical environment and have them observe providers and other healthcare professionals using the electronic health record, other information systems, and find out where does it work and where does it not work, and what are those challenges that we need to overcome by optimizing the technology. So, working with Marcelo and a number of other colleagues, we've actually built a tool. It's called TimeCat, and it's a web-based tool. It can be deployed on tablets, on phones, or on normal sort of desktop devices that supports multi-observer time and motion studies in the clinical environment. And it actually gives us a lot of capabilities, including the ability to support multiple observers to go in and collect this data, the ability to compare those evaluations, to visualize them, to deliver that information back to the people responsible for optimizing the EHR, and allow them to make better decisions. And by the way, we have a global user community. This is a free tool that we give out right now. And by the way, we also have people beyond the healthcare domain. We have everything from professional soccer teams to people in manufacturing and lots of stops in between using this tool to conduct time and motion studies. And it's a powerful tool. The point is, this is a tool you could have today. There are thousands of people using it, conducting time and motion studies, finding out where technology works and where it does not, and making smarter decisions to make sure that the technology is usable and that the data that we capture as a result is high quality and comprehensive. And this, as I said, has been studied in many different areas, right? Everything from looking at sort of workflows around medication administration protocols and how variances affect clinical outcomes, to looking at sort of the impact on nursing productivity at the point of care as a result of switching between various tasks and using the EHR and medication reconciliation and other tasks, to more general studies of how people study EHR impact on clinical productivity at a high level. And by the way, these are all publications, not all by our group, but by our users throughout the world that are in the peer-reviewed literature today, where these studies have been conducted and reported upon using the TimeCat tool. And by the way, for everyone in the room, I do have a URL at the end of this slide where you can get, or at the deck where you can get the slides. You're welcome to take pictures too if you want. I'm not averse to that. Again, I won't sort of belabor the point. We also see studies in ambulatory settings. How do we increase efficiency there? We see studies around the collection of research data, in this case in a rheumatology disease registry. And we actually see the use of the tool for understanding better how to integrate mobile device data with the EHR to support clinical care. And I'm just giving you sort of snapshots of really dozens and dozens of papers that have used this tool to improve the usability and workflow integration of electronic health records and other clinical information systems so that we can both take better care of our patients and also conduct research at the point of care. So, I hope by now I've convinced you that that first myth, that usability and workflow integration is a barrier to collecting high quality data or doing the type of work I'm describing, is just that, a myth, because we have the tools and methods today. It's just a matter of using them so that we can achieve these outcomes. So let's talk about myth number 2. Data privacy and confidentiality make it too hard to get data out of the EHR. How many people in this room feel like you run into problems in terms of getting permission to get data out of the EHR? Yes, you're raising your hand. Yes. Right. I'm worried that you're raising your hand, but we'll talk more about that later. Okay. I don't think that this is actually a problem. I think, again, that we have a variety of tools that allow us to responsibly use data produced at the clinic or in the hospital for research purposes that allow us to respect privacy and confidentiality, but still make that data available. And the question is, are we using all those tools today to make our lives easier? So again, we have tools that are widely available to de-identify, to scrub data, to produce synthetic derivatives. Now we're talking about what we call Federated Analytics, where rather than even looking at the data, I just send my algorithm to you, you run it against your data and send me back a result. And then a variety of differential privacy approaches, including a topic I won't even spend time on, which is the use of blockchain. Can't go to a meeting without someone asking me about blockchain. I still remain very confused about the practical application of blockchain in healthcare, and I would be very happy to be educated on that by someone who's actually used it to solve a practical problem. But that being said, now that I've disparaged the people working in blockchain, I want to talk about data synthesis, which I think is a very powerful tool. So at our institution, we've entered into a strategic partnership with an Israeli company called MD Clone, and they have a synthetic data engine. I'm going to show you how it works in a moment, that allows us to create an on-demand synthetic derivative of our clinical data from our EHR that statistically is identical to the real data, but has no linkage to real patient identifiers. That means it's not regulated by institutional review board requirements. It does not require any approval by the privacy office. You can literally point and click and use the data and run your analyses against it. And we've actually tested it, as is listed here, in a variety of use cases, doing head-to-head comparisons. How does this synthetic data compare to real data if we're doing descriptive statistics or machine learning or geospatial reasoning? Is it truly as good as the company claims it to be? So let me give you a concrete example of how it works. Imagine for a minute that you find a cohort of patients, let's say patients that have a certain type of cancer. You find that group of patients in your data repository. You then select a set of features for them. These are the measurements from the electronic health record. And then you synthesize those features and produce an on-demand derivative that you can actually analyze. How does that magical synthesis process work? So imagine here at the bottom, and this is me attempting to explain multi-dimensional space in a two-dimensional slide, so I apologize in advance for that. But imagine for a minute that there's a feature, right? In this case, we have features 1 through n for this population of patients. For each one of those features in a two-dimensional space, there's a distribution of measurements, right? A density function for where all the patients in that particular cohort reside. And if you plot the measurements that correspond to each individual patient across those multiple dimensions, you create a vector, right? So each one of these black dots represents a measurement for a real-world patient, and the vector shows how they are related to that single patient across those multiple dimensions. In this case, we can have multiple patients in that space. What the MD clone engine does is create new vectors. These are measurements that adhere to the density function in each one of those two-dimensional spaces that are statistically not significant in their difference, but do not directly overlap with the measurements of the real patients. And therefore, we produce a new set of vectors that replicate the behavior of the real patients in the multidimensional space, but have no relationship to their real identities. Right? Now, there's a lot of computational magic behind the scenes that makes this happen, and I won't sort of go into all the details, but I just want to show you the results. So we actually conducted a study where, like I said, we put this synthetic data head-to-head with real data and said, how does it perform for the types of analyses that people like us in this room would be interested in? And in particular, we looked at sepsis, right? And we looked at, could we develop machine learning algorithms that would predict sepsis onset in advance of standard diagnostic criteria, and how did those algorithms perform when we trained them on synthetic data versus real data? This is the basic idea. I always love this is like the simplest version of what is a very complicated project. But basically the idea is that we have a time of onset of sepsis. We want to see, could we get back 6 hours? So these are for patients in general units in the hospital that may be becoming septic, and we want to send one of our critical care teams to go see them and perhaps intervene before they have to go to the ICU. And then can we look back 24 hours from that 6-hour window, look at all the data for those patients, post-admission, but pre-6-hour window, and then apply a series of predictive algorithms to it to see, could we predict which patients are going to become septic and which are not. I love it because there's these 5 features over here that we talk about. This represents actually close to 2,000 discrete variables extracted from the electronic health record. And I would point out that this project uses real messy data out of the EHR, not data that's been scrubbed and cleaned and subject to a lot of quality assurance, but the real data that would be produced out of an EHR in the clinical environment. Now this is a slide which I have to tell you, I often jokingly refer to as the sort of funnel of despair when we talk about predictive important piece of information. I could show you lots of other data about this. Our best predictive model for sepsis risk in that 6-hour windows was a random forest model, which you see the results here, for the training, tenfold cross-validation, and test sets. And as you can see in the green box, our accuracy of predicting 6 hours out is right around 84 to 85%. But the really important thing is that the left column is when we trained the algorithm on real patient data and then tested it on real patient data, no synthetic data. And on the right side, we trained it on synthetic data and then tested it on real data. And what do you see? Basically no difference. We can train a machine learning algorithm on synthetic data derived from the EHR that doesn't have privacy and confidentiality risks and get the same performance as if I had trained it on real data. What does that mean? I can suddenly do things like the Netflix challenge, right? Where now I could crowdsource the development of these types of algorithms because I no longer have the privacy and confidentiality concerns. Or I could give it to students for a student project. Or I could give it to partners in industry. Or I could do all 3 things. The point is that we're showing here, and we can show this in geospatial reasoning, we can show it in traditional statistical measures, that we can use synthetic data for these types of data analytic tasks, and we can get the same types of results as if we had actually done these analyses in real data, but we removed the privacy and confidentiality risk. Our privacy officer and our IRB agree that this data is not human subjects data, and we are able to give it to our users with a simple data use agreement that they sign online and about a 60-minute online training module. That's it. and then they can point and click in the environment and go get their own data and do these types of analyses. So I hope I've convinced you. Myth number 2, not as big of an issue. Myth number 3, vendors are difficult to work with. We were just talking about Cerner earlier in the hallway. One of many vendors. I'm not going to pick on Cerner. But my point is, vendors bring interesting dimensions to the table because now we don't control our own destiny in terms of how we use these technologies. We have to partner with the vendors. A lot of people say it's too hard to work with the vendors. We're never going to be able to pull this off. Okay. We have a lot of tools to instrument the electronic health record today that will allow us to achieve our goals without having to engage in painful and difficult negotiations with our vendors, right? We have all sorts of APIs, certainly FHIR and the other sort of open and standard-based APIs. Common data models, right? Now things like we're extracting data from EHRs and representing it in the OMOP common data model allows for joint analytics across multiple sites. All sorts of data interchange standards, and then frankly, most of the really successful projects that combine some features of the prior 3. So, I'm going to give you an example of clinical decision support that's driven using exactly what I just described, which is a project that myself and my colleague Randy Foraker and Albert Lai worked on first at Ohio State and now continue to work on at Washington University, and it's a project that started out as what we called SPHERE. And this is actually, if nothing else, a diagram that proves that informaticians produce diagrams of boxes and lines, and then engineers actually turn them into working software. But the point is that this is a system that takes data from the current encounter with the patient, combines it with a historical view of that patient's same data from a data warehouse, and calculates an on-demand risk assessment for that patient's cardiovascular risk profile that can be used to inform shared decision-making at the point of care. And this is done using standard APIs and standard data models talking to a major commercial electronic health record without ever having to pick up the phone or talk to the EHR vendor because we just use those standards exactly as they are designed to be used. And this is what it looks like. The only problem in our case is that our EHR vendor doesn't allow us to show screenshots of the EHR. They would actually sue us if we did. So instead, we show a mock electronic health record, but I assure you this works with the real EHR. And what you see here is actually sort of a mock EHR, and then in the right hand, this is the tool that we talked about. Let me blow that up a little bit for you. So the idea is that it pulls historical data as well as current encounter data for that patient and calculates the American Heart Association Simple 7 criteria, which are modifiable behavioral risk factors for cardiovascular disease, and shows them actually on a visual analog scale. But you might also notice that these are sliders. And why is that important? Because we actually allow the clinician and the patient to adjust those features so they can have a conversation about this is your baseline, and if you brought your cholesterol down or your blood pressure, here's how it changes your overall risk profile. So it's dynamic and interactive. The idea is it guides a patient-provider discussion, and we're able to store that data. We can also get additional data from the patient through a supplementary data entry interface that captures certain behavioral information that's not in the EHR. And the real value is actually this is fully workflow integrated. This might be a fuzzy picture of a real EHR running on a computer, but this is it integrated with a commercial EHR at the point of care, displayed on the same screen. The provider does not know that they're not interacting with a decision support that's triggered inside the EHR, and all the data flows freely bidirectionally between the EHR and the tool. And here's the important takeaway. We did a practical study of this, a clinic randomized study, and we were able to show, and here's the takeaway, that when we did case control matching in these patients, we could get statistically significant changes in patients' body mass index and hemoglobin A1C simply by deploying this information at the point of care. No new medications, no new therapies, just giving them this information so we could support shared decision making at the point of care, and the patients that received the decision support intervention had improvements in 2 critical modifiable risk factors for cardiovascular disease. So I want to repeat that. Same impact as if we'd given them a new medication, but all we did was organize the information and deliver it in an actionable format so patients and providers could understand it. And we built the entire thing using standard APIs and standard data models that our vendor EHR support. And we have a project right now where we're looking at this for cancer survivors with multiple sites on various vendor EHRs, and it still works that way because those EHRs do support these types of standards. And there's a number of articles out there about sort of the usability of it for stroke prevention, cardiovascular disease risk, and the like. So again, I hope now I've dispelled the rumor that working with vendors is too hard and that we can't possibly instrument the EHR because there's going to be all these roadblocks. We have lots of great standards and lots of great tools. We just have to use them as they're designed, and we're able to achieve these types of outcomes. And this one's for you, Alejandro. 4th sort of myth.
IT organizations are too hard to work with. So even if we could overcome the first 3 issues, our IT professionals aren't going to let us do what we want to do. So there's a lot of ways to make this dynamic work well. And it all starts with shared understanding and governance between the IT groups and the informatics and data science investigators, right? We all need to know our relative roles and responsibilities. What I do as an informatics investigator is not the same as my CIO that has to make sure that the system is running 24/7, 365. We have different skill sets. I'd like to think of them as complementary, but I need to understand where my skill set ends and where theirs begins, and vice versa. The second is that we have to have shared leadership, because a lot of these projects that I'm talking about require us to get beyond just production deployment of, say, a vendor system, but think about where are we innovating and what's our innovation agenda and how does that fit into our overall business strategy as an organization. We have to have formal processes for evaluating these types of interventions at scale. The example I just gave you of that clinical decision support alert, we had to build that working in conjunction with our IT organization to make sure it was safe and secure and scalable. So if we put it into a clinic and real providers were using it, it didn't break and actually impede our ability to take care of patients, right? That requires a rigorous process of making sure that we understand those features. And then lastly, we have to build these rapid learning healthcare systems where IT and informatics work very closely with one another to create these continuous feedback cycles between all these areas. Now, I'm often asked when I say this, well, okay, I don't understand the difference, right? You know, when I go into the hospital, sometimes even though I direct the Institute for Informatics, I'll introduce myself to people and they'll say, oh, it's so great you're here. I'm having a hard time printing from the EHR. I don't fix printers. I don't know how to fix your printer. It's not my skill set. Likewise, when I go meet with people in our School of Engineering, when we talk about this, they say, well, what kind of new algorithm development are you doing for machine learning, right? Well, that's what computer scientists do or statisticians do. It's not what I do. I apply those algorithms and find out, how are they efficacious. That's not my role. And this is about understanding sort of the strong but synergistic relationships between computer science, informatics, and information technology, right? And in my world, I think of it as the computational scientists and the data scientists really help us come up with the theories and methods that allow us to make sense of data. The informaticians study how those theories and methods have impact on real-world driving biological and clinical problems. And when we have something that works and we need to deploy it at scale, we hand it off to our technology partners in the information technology world to make sure that it's secure, scalable, and safe to use in the real world. And there are fuzzy boundaries at each one of those intersections, but this is a critical understanding. I don't do what a computer scientist does, nor do I do what an information technologist does, but we actually do work across the continuum from discovery to practice. Now, I do want to say that if you go back to my argument about past year's quadrant, that places informatics very clearly in that sort of use-driven research category, not just basic science and not just applied science, but squarely in the middle. And this is actually something I've been working on with my colleague Chris Longhurst, who's the CIO at UC San Diego Healthcare, which is this idea of what is the model via which informatics and IT truly interact with one another in a learning healthcare system. And our view is that if you think about it on sort of a research cycle of basic and preclinical research to verifying and validating those discoveries, to scaling and delivering real-world settings, and then optimizing and measuring impact. At each one of those levels, there's some set of contributions either by informatics scientists or by technology practitioners, and then at these intersections, both. And the idea is understanding the cycle via which sort of these innovations are developed, evaluated, and deployed, and then optimized, and then we repeat the cycle, and the roles of everyone in that process gives us clarity over who is meant to do what work, and where are the handoffs, right? Where do I hand off my discovery and say to my CIO, okay, we want to now deploy this and study it at scale in the health system. Let's go forward and do that work. But within that framework, I also want to emphasize a really important role, which I think we often underestimate. And there's this great article that was published last year in Harvard Business Review about this concept of the data translator. Because in addition to the informatician and the technology professionals and the computational scientists, there's another critical role. And that's the role of the people who understand the data that we have, the problems that we're trying to solve, and how to evaluate them. And these people aren't computational, they're not necessarily informaticians, and they're not necessarily technologists. They tend to be clinicians and researchers and educators who bring those problems to the table. And I would argue that almost every successful informatics project involves a combination of computational scientists, informaticians, technologists, and data translators. Those are sort of the four pillars that make for a successful project. And I'd also argue that if you don't have these data translators involved, you may not in fact be successful in solving a real problem. So if you haven't read this article, much like I gave you homework to read past year's quadrant, I would also highly recommend that you take a look at this article in Harvard Business Review, which I think is a really important viewpoint on the role of the data translator in the data-intensive enterprise, which I think we could all agree that health and life sciences is. So that just a few final thoughts to wrap up. So if you look at sort of the environment that we're in right now, we've had an incredible period of evolution, right? If you go back just a few decades, we were collecting the bulk of our information on paper, right? In fact, medicine was one of the last places in the modern economy to adopt digital technologies to document critical data. And now, in a short time period, we've gone from paper to talking about building these learning healthcare systems with rapid evidence generation cycles based on the use of electronic health records and other systems. I don't think we should be naive to the fact that this change has happened very rapidly, and we're still learning how to thrive in this new world order. Very few industries have had this pace of digitization as healthcare has in such a short time period in recent history. And so it is important to be cognizant of that and not sort of get too aggressive in our thinking about what we can do, given all the change that we've endured to get here. I'd also say that there's lots of interesting things on the horizon because that evolution I talked about has been really driven in large part by this incredible growth in technology available to us to solve these problems. Now this time scale is a bit longer, it goes back to 1900 until present, but think about this. Around 1900, we were talking about building mechanical computers, right? Charles Babbage's analytic engine that allowed us to prove things like Bayesian statistics or engage in some of the earliest research on cryptography. These were literally mechanical computers made of gears. Today, now over on the right-hand side, we have quantum computing. So how many people in this room have read about quantum computing, right? So quantum computing is one step away from magic because quantum computing allows us to answer questions in multiple dimensions, and this is the thing that I love, and feel free to use this in conversation. If you try to observe a quantum computer while it's computing, you'll actually stop it from working properly. It's basically the situation that it's one step away from magic, because if we try to observe a quantum computer, we disturb the physics that makes the quantum computer work. That is sort of the brave new horizon of computation on our doorstep. And the point is, we should always be cognizant of how these rapid changes in technology impact our ability to do our work. If we put all these pieces together, if we think really critically about it, what are we trying to do? We're trying to leverage computing to create this integrated and high-performance system in which research and care happen side by side. And I would argue, back to the original premise of this talk, that it comes down to three things. Building that learning healthcare system in which we're instrumenting the environment and getting all this high-quality data and allowing for us to feed sort of new knowledge back into that environment. It's also about precision medicine, which I didn't talk about today, but that's how we actually think about understanding that data. So rather than thinking of our patients as a function of averages, we actually think about how their unique measurements drive their unique response to therapy or their unique risk of disease. And then lastly, that we engage in systems level thinking and we use informatics tools and other methods so we can really sort of wrap our arms around all this big data, right? It's a very popular term, but big data is not just about the size of the data sets, it's about the complexity and the speed with which it's produced and sort of its variability. And I think we have all of those features in abundance in healthcare, and so we need to adopt those really modern approaches to solving those types of problems. And at the end of the day, that puts us in a position where we're learning every time we interact with the patient. We're leveraging the best science to improve care for our patients, and we're really solving those truly complex systems level problems that previously had not been possible to solve. Now, I'll leave you with a quote, which is one of my favorites, which is that it's not about how big an organization you are, or how much money you have, or what great technology you have at your fingertips. I think right now, with all the changes happening, as we think about building a true learning healthcare system, the thing that's going to define those academic and delivery enterprises, or more broadly, those sort of healthcare organizations that are going to thrive in this sort of new world order, are their willingness to change. Because none of the things that I just described are going to work in the traditional way of doing business in healthcare, whether that be from an education, research, or practice standpoint. And so that willingness to change, to try new approaches, to sort of upend business models, to become progressive in our thinking, is central to taking advantage of all of the sort of opportunities that I've outlined here. And so with that, I want to point out, if you take a look, and I'll post a link on Twitter to a version of these slides. If you ever want to know what I'm thinking about in terms of the current state of big data, computation, healthcare, take a look on Twitter. You can always email me, and if you're more interested in what we're doing in many of the areas that I just outlined at Washington University, take a look at our website at informatics.ursula.edu. And with that, I'm happy to answer any questions.